तो आपको पता है कि चोरी के फोन्स छोटे क्राइम से लेकर टेररिज्म तक में यूज होते हैं, बट इसे रोकने का एक पावरफुल टूल गवर्नमेंट ने सबके हाथ में दे दिया, जिसका नाम है सेंट्रल इक्विपमेंट आइडेंटिटी रजिस्टर यानी CEIR। गवर्नमेंट की इंपॉर्टेंट सर्विस पिछले महीने ही पूरे देश में रोल आउट हुई और इस साइट के डेटा का एक और यूज है जो इस वीडियो के एंड में बताऊं। पहले आपने CEIR नहीं चलेगा और तो और पुलिस को अलर्ट कर दो। अब इस पोर्टल का दूसरा फायदा,
Dr. Gaurang, should we start or we should wait?
I think we should start now. Just or wait for 1 or 2 minutes. I think Dr. Ganesh Bakshi may join.
We will wait for 2-3 minutes more. Then we'll start.
Yeah, and then we'll start. So, Dr. Vijay, today we are taking a discussion on this thing, metastatic hormone resistant. Correct? So you can be, first 35-40 minutes, we'll just have a one case discussion and you can guide them how to go about. And then you can give your suggestions or your lecture, depending on that.
Okay, we will do that. We'll do that. No issues. Yeah.
Dr. Swastik, can you share the screen? So who is answering today?
Sir, I am answering, sir. Dr. Tanmay here.
Dr. Tanmay.
Yes, sir.
And Ajinkya. Who else is answering? Dr. Ajinkya?
Sir, good evening. I am Dr. Sai. I am also answering, sir.
Okay. Can you make Dr. Swastik co-host?
Good evening, sir. I'm Dr. Niraj, sir. I'm also answering.
Okay.
We know you now.
Okay, I think now we can start. So, Swastik, what is happening? Swastik, you can use Dr. Paras's laptop if there is any problem.
Good evening, everyone.
Good evening.
Should I start, sir?
Yeah, please start.
Swastik,
Sir.
last two classes, we have already covered the history part.
Yes, sir.
So you just present this case as a short case in exam.
Okay, sir.
Like chief complaint,
Yes, sir.
short positive negative history and
Yes,
local examination.
Okay, sir. Okay, sir.
That's
Sure,
all.
sir.
So we can directly enter into the desired area as soon as possible.
Okay, sir. Okay, sir. I will-
Swastik, you keep on presenting unless sir stops you. Okay.
Yes, sir. Sure, sir.
Yeah.
So there was a 72-year male resident of Mumbai presented to our side with complaint of difficulty in passing urine for last 12 months. Patient was apparently asymptomatic 12 months back when he started developing difficulty in passing urine with poor flow associated with insidious in associated with straining, insidious in onset, gradually progressing with no specific aggravating or relieving factors. It was associated with nocturia, which was 3 times per night, and IPSS score was 19 out of 35. There's no history of burning micturition, no history of abdominal pain, fever, no history of vomiting, no history of hematuria or lithuria, no history of facial puffiness, exertional breathlessness, or lower limb edema, no history of jaundice, no urethral instrumentation in past, and no history of medication. No comorbidities, and there was no family history of cancer related in the patient's family. Personal history: patient was vegetarian by diet. He has a history of decreased appetite for over last 3-4 months, and history of malaise and subjective feeling of weight loss for over last 4 months. Bowel habits are regular. Bladder as altered as described earlier. Sleep is disturbed due to nocturia, and patient is a non-alcoholic, non-smoker, non-tobacco chewer, and he is not sexually active at present. On examination, patient was conscious, cooperative, and well-oriented, time-pleasant person. Pulse was 80 beats per minute. BP was 130 by 80 millimeter of mercury. Respiratory rate was 16 per minute. He was afebrile on examination, and saturation was 98% room air. There was no evidence of pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. There was the spine examination was normal. Karnofsky score for the patient was 70. And before examination, patient examined in supine position with exposure from nipple to knee. External genitalia were normal, non-circumscribed, forced was detectable, and external meatus was normal. All hernial orifices normal, sputum was normal. Correct examination was done in six position. There was no fissure, fistula, or hemorrhoids. Anal tone was normal. There was grade 2 prostatomegaly, hard in consistency. Nodularity was present more over left lobe, and it was non-tender with mobile rectal mucosa. There was no blood on the gloves. For abdomen examination, patient examined in supine position with implied informed consent with exposure from nipple to knee in adequate dim light. Inspection, umbilicus is centrally placed, all quadrants moving equally with respiration. On palpation, there was no localized temperature, no tenderness over abdomen.
So Tanmay, just summarize the history and what are the differentials in your mind?
So 72-year-old male presenting with difficulty in passing urine, specifically complaining of poor flow and straining for the last 1 year, along with increased frequency with the IPSS score of 15, with the only other positive history being complaining of malaise and weight loss for the last 4 months. So considering the history, sir, my differentials first would be benign or malignant, more likely a malignant.
When examiner asks at the end of the history presentation, that means he has completed history, has completed digital rectal examination. Important point you are missing.
Yeah,
along
okay.
with the history, 3-4 point. KF score
of 70, a grade 2 hard nodular prostate with a mobile rectal mucosa with nodularity.
You have to combine all the things in one go and just tell 1 or 2 differential.
So my main differential will be malignant, CA prostate, sir. Malignant enlargement of the prostate.
So what are the things you found in this history and physical examination to label it as a malignancy?
Firstly, in the history, the presenting complaints are mixed FACULTIES along with weight loss, with on examination, slightly decreased Karnofsky score along with the hard nodular prostate. Are grade 2 hard nodular prostate are my likely reasons for CRPC.
So presence of hard nodular prostate is only sufficient to label it as a malignancy.
No, sir. There are other differentials.
So there are a number of causes for having a hard nodular prostate, nodularity as well as hardness. So your diagnosis should be bladder outlet obstruction, maybe benign or malignant, probably malignant.
Oh, yes, yes.
Okay, then how will you go ahead?
Sir,
any other history or investigations you want to ask to him?
In history, I'd like to know history of backache or bony pain, sir. That would be one thing.
Yes. So that means if you are expecting a bladder outlet obstruction, then you have to ask the history of complication of BO.
Yes.
Or history of complication of the CA prostate. So yes. Complication may be locally related to the locally advancedness or to the metastasis. So these are the constitutional symptoms, then metastasis to the bone, metastasis to the viscera, then involvement of the surrounding structure, that means rectum, bowel. So all these things can be asked now retrospectively to confirm or reconfirm your diagnosis.
Yes.
So how will you proceed?
So I would initially proceed with the routine blood investigations, including a CBC renal function test, urine routine. And along with that, I'd like to do a serum PSA as a specific investigation.
Okay.
So only one thing, what is a differential diagnosis of hard prostate on PR?
Sir, it will be tuberculous prostatitis, chronic prostatitis, prostatic lymphoma.
The causes of hard prostate, the causes should be on the tip of your tongue. So like one you are told tuberculosis, another you told there may be calcification, another you told there may be prostatic infarct, another you told another is the malignancy, any other fungal prostatitis. So these are the causes, 3-4 causes. The examiner asks, that means you 1, 2, 3, 4, 5 आना ही चाहिए, तो ये क्वेश्चन आगे चला जाएगा. ठीक है? So whatever the investigation asked by Tanmay, please tell.
Sir, Tanmay, one question from my side.
Yes, sir.
If suppose this patient is complaining of upper backache.
Yes, sir.
What you will think? With the same finding with upper backache.
In terms of distant metastasis to the spine.
Okay. Okay. With such LUTS with IPCS score of more maybe 25, and then upper backache.
Upper backache means what? It be in the central place, along the spine, the paraspinal area, along in the renal angle, lower chest, where it is.
Patient will say the back there is a pin back. Okay, not right, left, maybe bilateral. Okay, so you should have suspicion in your mind as per the patient complaint. Now tell me, I think Gite sir has already given the hint.
So it could be firstly tuberculosis with the involvement of spine, or if it is unilateral, maybe he's locating it to a flank. Could be possible involvement of the ureteric orifice leading to hydronephrosis on one side, causing the pain.
Only one side, can't be bilateral.
It can be bilateral, yes.
So whenever if you are suspecting clinically it is a prostate, that means a bilateral flank pain or upper backache, you can have you should have suspicion of bilateral ureteric orifice involvement by the disease. Okay, either by the tuberculosis or by the malignancy or by the BP also. Okay, Yeah.
Should I go ahead, sir? Next slide.
Yeah. So
So
no.
on
Okay.
investigating
What are the investigations you'll ask now?
Sir, I'd like to ask for a routine CBC and renal function test along with serum PSA as a specific investigation initially.
Should I show the investigation, sir?
Yeah.
Yeah. Yes.
So patient's hemoglobin was 12.6, total counts are 8,480, platelet count was 3,44,000, serum creatinine was slightly raised, it was 1.57, liver function test was normal, and serum PSA was 154 nanogram per milliliter.
So,
So Sai Krishna, now what else? These are the investigations. What else you want?
Sir, he's having serum PSA of 154, and the clinical examination shows that it is most likely the carcinoma of prostate. So, in this case, I want to do some investigations to trace the disease, and I would like to do CCT abdomen and pelvis along with bones cancer.
Okay, any better investigation
Sir, PSMA PET, sir.
before that?
So trust biopsy to confirm the diagnosis.
Sorry, yes.
Well, CT and bone scan also, it is also agreed in exam as old examiner may agree. But what current guidelines advise in such situation, which should be the best investigation for this patient? Tanmay.
Sir, I'd like to do a trust-guided biopsy first to confirm the diagnosis of prostate, and then for
already we discussed last two classes. So biopsy first or MP-MRI first?
Sir, with the current PSA of 154, possibly disease is already metastasized. So in this case, I'd like to go for biopsy first, sir. If I was suspecting a local or locally advanced disease, I'd prefer an MRI.
So after biopsy, you don't want to go for MP-MRI?
No, sir. I'd like to go with the biopsy and then PSMA PET, sir.
So with biopsy, you directly go to PSMA PET scan. Okay. That is one approach for such patients. Agreed. So what has been...
One question, sir. Sai Krishna, how will you justify ultrasonography? Because now you know that PSA is 154, but when you are asking for the investigation, you will always ask for the ultrasonography. So how will you justify?
Sir, ultrasound, it's extension of the clinical examination, sir, and it is cheaper and easily available. Even the ultrasound, even we urologists also can do that. But in order to have the better staging, I want to go with the CCT abdomen and pelvis along with the bone scan in this case, sir.
See, first of all, before you have got all the investigations in your hand, except that hard prostate, you are not very sure whether it is 100% CA prostate or not. Correct. So ultrasonography will give you, even if it is non-malignant, then it will give you other information like what is a post-void urine, whether any other pathology is there, like a stone disease associated with that. What about the upper tract? And as you said very rightly, it is a extension of a clinical examination. So you can justify with that. Fine.
Also, grossly enlarged lymph nodes, metastasis, liver, visceral, all those things you can get. Huh? So don't just close your mind. Be an open mind. Like sir said, you'll get to know about the bladder, stones, large median lobe, very high residual urine, upper tract, large pelvic nodes, visceral metastasis. All those things you get to know.
Yes, sir.
Agreed. So there is, before going for CT scan or MP-MRI or PET scan, ultrasound and uroflowmetry in this patient, if somebody tell in exam, that can be accepted and it is required to do also, because patient presented with lower urinary tract symptoms of mixed type.
So let us ask now Dr. Vijay, as an examiner, what are the things you will advise them?
So as an examiner, first of all, I always look at the approach. So my approach is very simple. For any cancer, it is investigation for confirmation of diagnosis. So that's always a biopsy. And the simultaneously investigation for staging. And I would agree with Dr. Gite here. With the PSA 154, there is no point wasting time. Just get the first a PSMA PET done. So agreed ki old time examiners would go for bone scan and MRI. And there is data also to say that if your PSA is above 10 nanogram per ml, PSA with this high PSA, the sensitivity of PSMA PET is the slightly only higher than the conventional imaging. But the PSMA PET becomes a one-time. And the second thing was really then work up for fitness for treatment for the patient. So that's what I teach my DM student is if you want to tell the examiner what are my investigations, it should be in a one go rather than he keeps asking you. For diagnosis, I want to do this. For staging, I want to do this. For diagnosis, I want to do this. Done. So let him move on with the next question.
Agreed.
So I think Dr. Vijay has told you regarding all the cases. This is a way you should ask for the investigation. So Sai or any one of you can now in one go, can you tell us what are the investigations you'll ask?
Sir, for confirmation of the diagnosis, I want to do the trust-guided biopsy. And for the staging purpose, I want to do the because serum PSA is 154 and on parietal it is showing the hard nodules. So I want to go with the PSMA PET for the CCT abdomen and pelvis and bone scan, or else I will go with the PSMA PET scan in this case.
So Tanmay, if the PSMA, you are in a place where the PSMA PET scan is not available. So now what you will do?
I'd go for a CCT of abdomen with a CT thorax and a bone scan.
Fine.
So whenever you say this is bone scan, be specific which bone scan. Is MDP technician bone scan? Be specific. Bone scan because there are also fluoride PET bone scan also there, sodium fluoride bone also there. Very, very specific. Okay.
Yes.
So as already sir is asking, which bone scan is better?
Technician MDP bone scan.
Which bone scan is better? Fluoride or MDP?
MDP.
Okay.
Can MDP diagnose the metastasis in bone marrow or bone marrow involvement?
Not sure.
Mahendra?
Yeah. So as Dr. Vijay said that it is nowadays, it is better to do one imaging if it is available, which can give you the full information. So what happened in CA prostate, even in PET scan, PSMA PET has a very good specific sensitivity because it can diagnose the soft tissue as well as the bony lesion. Soft tissue includes any visceral mats, any nodal mats, okay, and bony tissue means any bone marrow involvement and the bone involvement. The other investigation, whether it's the fluoride 18, PET scan, MDP, POD scan, they're only specific for the bones. Okay, so that's why PSMA PET scan is nowadays is available, is the investigation of choice. And if you see the guidelines from last 2 years and latest guideline, previously PSMA PET was not as a recommendation thing because now it's a widely available. Now PSMA PET is a investigation of choice for the for the metastatic CA prostate. So that is the reason why you should do either PET colon or PSMA PET scan, because they have a very good sensitivity of soft tissue as well as the bony disease, bony lesions. Okay.
So is there any preference in bone cancer, MDP or fluoride?
Definitely PSMA and fluoride. Fluoride is more specific than the MDP bone scan. Okay, MDP bone scan has a sensitivity only 40 to 60, 50%. And as somebody wrote, PSMA PET scan has a more than 90%.
Is there, I think there was some, one of the lecture they had mentioned the difference between the bone scan and the PSMA PET scan, that the bone scan is, I think, more precise for the bone marrow or medulla, and the PSMA for the cortex. What is the relation? Can someone tell me?
Along with bone diagnosis of bone metastasis, fluoride bone scan is more preferred to diagnose the involvement of bone marrow, replacement by malignant infiltration or bone marrow metastasis. And MDP is less preferred or less sensitive for diagnosis of bone marrow metastasis. That's what I feel. So anybody can confirm if I am wrong.
No, sir, you are right. You're right. One more thing, to confuse you, examiner may ask, what about FDG PET scan? It is also a PET scan and available everywhere, even more available than the PSMA PET scan. Why not FDG PET scan then?
So it has less specificity to
Why? Why?
It detects almost every inflammatory lesions are also detected by the they have the metabolically active in the FDG PET, whereas PSMA PET it shows only the malignant involvement of the.
Also, so the FDG works on the principle of the uptake of glucose 18 with the 18 fluoride marker. So the metabolic pathway in prostate
Metabolically active lesions.
So see how you get David from the question. My question was, why not FDG PET scan? Why only PSMA PET scan? And you are telling me the physiology of the mechanism of the FDG PET scan. Okay, the logic behind FDG PET scan. Okay, you should be specific and you are not writing theory. You are giving practical examination. You have to give answer in 2 lines, in 3 lines. Okay, and be specific. So the answer of this question is in prostatic tissue, the FDG uptake is very, very low. Okay, just like a RCC, renal cell carcinoma, for the primary. Okay, and again, the metastatic site also, the FDG uptake is very low. So it may be mostly it is equivocal finding. So that's why it is not recommended. Okay,
Yes,
this is the answer of not doing FDG PET scan in the prostatic cancer.
Okay.
yes, sir.
Yeah.
Fine. Okay, Swastik, go ahead.
So as we went for investigations, we also did urine routine examination and urine culture sensitivity. Urine routine was suggestive of pus cells 12 to 15 per high power field and red blood cells 16 to 18 per high power field. And urine culture showed no.
Okay, just show them. Yeah.
Yes, we also did an ultrasonography of the patient.
Read the result.
So the liver parenchyma showed a mildly increased echo texture. There was no focal lesion. And then pancreas was normal in size and echo texture. Both kidneys were normal in size and shape. The parenchyma showed normal echo texture. Corticomedullary differentiation was well maintained. Right kidney mid-pole calculus of around 2.7 millimeter was seen, and upper and lower pole classification was seen. In left kidney, 9 was normal in size and mid-pole classification was there. Urinary bladder was partially distended, margins were smooth, no cycle mass or calculus was seen. Pre-void was 38 cc and post-void residue was 9 cc. It was mildly significant, and prostate was enlarged in size. It measured 4.2 into 4.5 into 4.5 centimeter, and weight was around 46 cc. And there was no ascites or lymphadenopathy noted. So the impression was grade 1 fatty liver, right renal small non-obstructing calculus, and grade 2 prostatomegaly with mild significant post-void residue.
Okay, show them all other investigation because they have already asked.
Yes, sir. We did a uroflowmetry, which was suggestive of poor flow rates, and Qmax was 8.7 milliliter per second, and time to Qmax was 27 seconds. Water volume was 71 milliliter, and average flow rate was 2.6 milliliter per second. Going ahead, we did a trust-guided biopsy for this patient, and it was suggestive of a prostatic adenocarcinoma with Gleason score of 4 plus 5. It's 4 plus 5, that is 9, and with Gleason grade group 5. And going further ahead, we also did a PSMA PET scan for the patient, and this was the image, and the reports are as follows. In abdominal pelvis, the prostate gland was enlarged, measured around 40.6 cc. It showed intensely increased tracer uptake in right mid and basal sextants. Superiorly, there was increased tracer uptake noted in the right seminal vesicle, and median lobe hypertrophy was seen bulging into the posterior wall of urinary bladder, with indistinct fat planes with urinary bladder anteriorly and rectum posteriorly. Lateral fat planes and bilateral levator ani muscles were maintained. Moderate to intense tracer uptake was seen in multiple perirectal lymph nodes, and there was multiple hypodense lesions seen in both lobes of liver. bone on osseous examination, increased tracer uptake is noted in multiple sclerotic lesions of axial appendicular skeleton. Few representative lesions were in the lesser trochanter of right femur, sacral promontory, left humeral head, and right glenoid process. So the final comment was prostate gland was enlarged with intense increased PSMA uptake in right and basal sextants with indistinct fat plains with bladder rectum. Primary malignant neoplasm was the impression, and there was intense PSMA uptake in abdominal pelvic lymph nodes, skeletal and hepatic lesions. No PSMA expressing lesion anywhere else in the body.
So this report is a classical example of why you should go to the PSMA PET scan, which you will not get in the MDP bone scan. Such detailed report you will not get in FDG PET and in a conventional bone scan. Okay. Yeah. So what next? Tanmay.
So with this finding of a high burden disease, metastatic disease, I'd like to start the patient on ADT with chemo with docetaxel, considering a KFS of 70 patients.
Okay. So this is why this is high volume? You said produce high volume. What is low
Greater than
volume?
equal to 4 bony metastasis with or without visceral mets according to latitude definition. So,
You said docetaxel. What was the creatinine?
It was 1.57, sir.
1.57.
Never miss these things.
yes.
Okay. Yeah.
So, Dr. Vijay, can you just give them some ideas how to go about? Because what we have done may not be the exact protocol, what you are following or what is given.
So if this patient sees me, there is no doubt that he is high risk because he has visceral metastasis. The age was 72. The creatinine was on the higher side. So actually what I would have done, I would have done a full functional assessment of this patient. We would have done a comprehensive geriatric assessment also for this patient. At the age of 72, with that creat, it would be in my experience, he won't have turned out to be fit for a triple therapy like ADT, docetaxel plus hormone. That happens most of the times. In all likelihood, so if the patient turns out to be fit, great, you can give. High creatinine is actually not a contraindication for giving docetaxel because docetaxel is actually destroyed by the liver. So in this case, my concern would be looking more at the OT and PT. So this patient, I would have done for fitness a CBC, a RFT, a LFT. You have already done that, a ECG, and a 2D echo for this particular patient, and a comprehensive geriatric assessment. If the patient is fit in all regards and the performance status is 0 to 1, definitely androgen deprivation therapy, hormonal or surgical, depending upon patient's choice and preferences and economic issues. If fit, then definitely docetaxel plus enzalutamide or abiraterone. But most of the times the patient may not be that fit. If he's not that fit, then androgen deprivation therapy plus abiraterone or enzalutamide, one of those things I would have chosen. Then depending upon the abiraterone or enzalutamide, it would depend upon what kind of stage. If he has hypertension, if he has multiple drugs for like say for diabetes, for congestive heart failure, then I would give my preference to enzalutamide. If he has a neurological history of seizures or neurological issues, then my preference will be abiraterone. So that's the way I would have chosen and then monitored the dose.
Fine. So now, Swastik, you just tell us how we treated this patient and what was the progression.
Yes, sir. Sir, initially the patient was evaluated and then he underwent a bilateral orchiectomy at our center. Following this, the patient was started on abiraterone therapy, and then patient actually presented to us with the lower reproductive symptoms. So the symptoms persisted, and patient was then taken up for a channel TURP. Then patient was on abiraterone and he was responding well. And at 6 months, the nadir PSA level of 0.346 was achieved post orchiectomy. After that, after 1 year on abiraterone, patient had developed cardiac issues like concentric LVH, which was evident on 2D echo. So patient was then started on enzalutamide, shifted on enzalutamide for further treatment. And actually patient then continued the medication but lost to the follow-up. And at 2 years, patient again started developing similar urinary complaints. So on DRE was a grade 1 prostatomegaly with hard prostate, and then was evaluated with serum PSA and ultrasonography. The ultrasonography showed both kidneys were borderline size, normal in shape. Right kidney was the parenchyma was normal, and ecotexture and corticomedullary differentiation was maintained. There was no evidence of calculus or hydronephrosis. Urinary bladder was partially distended, and margins were smooth. There was no vesicle mass, and pre-void was 110 cc. The prostate was post-operative, and no ascites or lymphadenopathy was noted in this.
Okay.
Going ahead, at 2 years, when the patient had presented to us, the PSA level was 3.11, which was way ahead from the Nadir values. Nadir value was 0.364, and it was 3.11 at 2 years. Then
okay, just wait.
Yes.
Okay, right. So now, Sultana, now this is a situation. Now, what is your conclusion and what you want to do?
There is an increase in the PSA, and the symptoms are also there for the patient. So this patient is having a recurrence. This patient is having on ADT. This patient is not responding to the ADT, sir, and also to the enzalutamide.
So what is it?
Dr. Vijay and Mahendra, you can just take over.
Yeah, so now the serum PSA was 0.3, now it is 3.11. So what is it? How do you define it? Why is it
You
so?
said recurrence. Would you like to use some other word?
Biochemical.
Castrate-resistant prostatic cancer.
Yes. Dr. Sultana just used biochemical. Biochemical recurrence is only used. This is the societal, actually, the word you use in this case. Okay, biochemical at your level. Biochemical recurrence only to be used when the patient has undergone definite treatment, either surgery or the RT. Then biochemical recurrence. In metastatic prostatic cancer, there is nothing called biochemical recurrence. Okay, so please be careful what terminology you are using in the exam. Okay, because some words and some answer are not excusable. Okay, so now Abhi, you tell me 0.3 to 3.11, 10 times increase. So what is it? What do you think? What is going on?
There is progression of the disease with which is resistant to the ADT. So call it as a castrate-resistant disease. But to define it, we need 3 consecutive samples at minimum 1 week intervals.
And what else?
With the two values greater than 50% of the Nadir PSA, and with a PSA of greater than 2 nanogram, or signs of new metastasis.
Or what else? The main requirement, the main thing.
With the testosterone at castrate levels, less than 15 nanogram.
15 nanogram, right? Okay, so it is 0.311. Dr. Vijay, now one patient, one person asked about the bone health. So how, I think we discussed last class bone health. So I think no need to repeat, Gaurang Shah sir. Or
yeah, let us. If Vijay feels that he wants to add something to that, in this case, he can just tell us again.
Yeah. So, like we discussed last time, whenever we start androgen deprivation therapy, we must always look at bone health also, and we must get a bone mineral density done. Now, giving bone modifying agent in a castration sensitive prostate cancer doesn't help for the disease per se, but if there is osteoporosis, that is, if the T score or Z score is below -2.5, it can help, but then the doses is at 6 monthly intervals. Now, When the disease becomes castration-resistant prostate cancer, at that time, yes, there is a role of giving bone-modifying agents. So that's the way we would proceed in this case.
Dr. Vijay, just sorry to interrupt you. Maybe
Yeah,
the old examiner may ask the role of complete androgen blockage at this moment. What is it? Complete androgen blockage?
Sir, giving two simultaneous modalities of
No.
and-
This was the treatment was a few years back when patient is after ADT, patient is serum PSA is rising. It was practiced to add anti-androgen. Okay, light bicalutamide and other thing for that. And eventually, it was found that eventually patient will develop into the CRPC, and that is literally resistant to the other therapies. So now that practice is stopped nowadays. Okay, so complete androgen blockage is not done. Once patient develops CRPC, you directly had to start the second line therapy. And now, Dr. Vijay, now you can go. No, it's your area now.
in
Completely.
fact, so when that practice is to be there, bicalutamide or flutamide, one of the first treatment used to be you stop bicalutamide and flutamide. So, and if you stop it, in some patients you actually used to get a response, and they actually used to feel symptomatically better also. So if you find a patient who has been started on bicalutamide and flutamide, first thing is you do stop without it. Okay, a few patients do respond with that simple intervention also. So what do you want to do now? Now it is 3.11 and this PSA is at 2 years. So what next you want to do?
No, I'd like to confirm castrate level of testosterone, sir.
This patient ka to surgical cochleectomy hua tha na?
Okay. So yeah, with that,
what next you want to do? So you have seen that the PSA has risen over at 2 years. It went down, and the nadir value was achieved at what time?
6 months.
0.6 या 0.3 जो हुआ तो कौन सा time पे था?
6 months. 6 months.
6 months back. So within 6 months, it has gone from 0.3 to 3.11. Okay. So what is the PSA doubling velocity here? पर PSA doubling time कितना है? कम है कि ज्यादा है?
ज्यादा है.
ज्यादा है. तो एटलीस्ट 6 months में अगर 0.3 से 3.11 हो गया है, मतलब definitely the doubling time is definitely less than 6 months. It's actually less than 3 months here.
Yes.
Okay. How many times it has doubled by any chance? Could you calculate?
Sir, more than 3 times.
Correct. 0.3 से 0.6 तक ही
0.3 to 3.1.
0.32 ना, तो 0.3 से 0.6 हुआ, 0.6 से 1.2 हुआ, 1.2 से 2.5. So at least 3 times it has got doubled. So definitely less than 6 months. At least actually it is 2 months.
Yes.
So now what next you want to do? So this is, let's say this patient has come. Let's for first discussion take that patient is asymptomatic. Patient doesn't have symptoms and he has come to you. What would you do now? Symptoms नहीं है, सिर्फ PSA करवा रहे थे patient और PSA बढ़ा हुआ आया, आपने अल्ट्रासाउंड किया, उसमें कुछ खास changes नहीं दिख रहे. What you would do?
So
do you want to do a radiological PSMA PET repeat this time?
Yes, sir. Yes, sir. To look
Why
for,
do you want to do that?
because there's a rising PSA, sir, I'd like to rule out any fresh metastatic lesions.
So your answer should be a bit more scientific. You always say in a sophisticated language it would like, so there is a serological progression. So I want to confirm whether the radiological progression or not.
Okay.
And now in CRPC, there is a difference in the treatment of a serological progression and a radiological progression, which is according to PSA doubling time. So it's better that you confirm that. Okay, let's say that this patient में radiological progression भी मिल गया, number of bone mets had increased, liver disease has also increased, and the PSA also has risen. Now what would you do?
sir. I think patient has already received abiraterone.
Patient has already received abiraterone. On abiraterone, he developed left ventricular ejection fraction. This was actually a good case, backing up what I was informing you last time, that cardiac issues do happen with abiraterone, and you need to be wary about that. So left ventricular ejection fraction, there was issue, so that shifted it to enzalutamide, and the patient has now got exposed to both abiraterone and enzalutamide, and ADT has been done. So what next?
So with this, I'd like to go ahead with a second line treatment with enzalutamide, sir.
नहीं, enzalutamide तो पहले ही मिल गया ना, abiraterone था, abiraterone के बाद enzalutamide पे shift हो गया. So let's catch that point. So let's say that the patient was on abiraterone, okay?
Yes.
Let's say that abiraterone, and now with this, do you think shifting to enzalutamide is a good option?
Usually both of them are equally efficacious.
So there is very limited data, prospective data after abiraterone giving enzalutamide. There are retrospective series which show that it actually does not benefit. That's why Dr. Gite was showing you the hand that no, you can't, you should not be trying that. Okay, so abiraterone okay, enzalutamide. So now what do you want to do?
Cabazitaxel, sir.
Patient performance status of the patient is.
So this is where the catch comes, Tanmay, now. So this patient, if so now evidence for using docetaxel upfront, if you thought he was unfit for docetaxel 2 years back or 1.5 years back, with progression there is very limited chance that the patient would be fit. And this is where the mindset now has to change. That see, once the patient progresses, उनका उम्र ज्यादा होने वाला है, comorbidities are going to become more uncontrolled. With disease progression, their fitness are going to fall. Okay, so if you want to give cytotoxic therapies, give early. Okay, do not wait for them to progress. Okay, and I'll tell you why also. So with that, actually now we'll Dr. Gite and Dr. Is it okay? Should we start the PPT so that we can tackle these issues in that? Yeah. So if you can allow me to share screen, I'll start.
Yeah. So I will stop my share, sir.
Okay.
So is the screen visible?
Yes, sir.
So this was what we concluded at the last time with castration sensitive prostate cancer. If the patient is CGA fit, it is comprehensive geriatric assessment, absolutely fit patients, high or low volume disease. Today the evidence is in more favor of androgen deprivation, docetaxel, or adding abiraterone or enzalutamide, a triple drug therapy. Now remember, when we get only androgen deprivation therapy, the survival was 30 months. Androgen deprivation plus docetaxel went to 40. When you give 3, the jump was to 60 months. So the average from androgen deprivation to when you go for all 3 drugs together is a jump of 30 months. Remember the figure of 30 months, and I'll let you know why that figure of 30 months is important. Now, whenever you have castration-resistant prostate, the definition is very simple. You should have documented evidence of progression. And as Mahendra boss was pointing out, you should have castrated level of serum testosterone. Now, progression can be radiological progression. We use something called as RECIST normally, which means that there is an increase in the number of bone lesions, or there is an increase in the soft tissue, which is more than 20% in the size. So let's say the initial size was 10, then it has to increase by 12 centimeter or more. 10 ka 11 ho gaya, it's not important. Now we have for PSA progression also, and this is where a little bit amount of confusion happens. The prostate cancer working group says that a 25% increase from the nadir. So it doesn't say from the baseline value. So you are actually supposed to put a chart in the patient's first page where you write PSA at each visit so that you come to know where the nadir was. And whenever you conclude from the nadir, it should be at least a 2 nanogram per ml increase. So in this patient, it went from 0.3 to 3.1, so it was greater than 2 nanogram per ml. The interesting thing is, now it may take 2 or 3 levels to rise above 2 nanogram per ml. So if you're participating in the trial, the point of PSA failure is not when the 2 nanogram per ml got crossed. It actually is when they started rising. Okay. Now, the European Association of Urology has very simple definition: 2 consecutive PSA rises of 0.2 nanogram per ml. And there should be at least a 1 month gap between them. NCCN guideline and ASCO does not provide any definition for PSA only progression. So the most accepted one is the prostate cancer working group 3 definition. So you can remember that. Now always remember, you need to have this PSA doubling time in your mind, and whether it is less than 10 months or not more than 10 months actually becomes important. Now we were discussing about a lot about whether we do a conventional technetium 99M diphosphotonate scan. And please remember in exam, whenever you say bone scans of multiple types, so always say technetium, always give the molecular weight 99M, and also on diphosphonate. And what it is seen is this conventional imaging strategy of having a bone scan plus CT, or if CT not the MRI, has very limited sensitivity, especially when the PSA falls below 10 nanogram per ml. If the PSA is about 10 nanogram per ml, the PSMA PET sensitivity is above 93%. For sensitivity, specificity, negative predictive, all are above 93%. That for the conventional is around 85 to 90%. But when the PSA value is below 10, at that time the conventional technique, sensitivity and specificity actually falls below 70 to 80%, and that time PSMA PET becomes much better. Now there is a catch here. We all are moving towards PSMA PET, but all the studies which are done for CRPC or CSPC actually have used the conventional imaging because they started around 7-8 years back. So you may land up in a situation where the PSA is rising, conventional doesn't show anything, but PSMA PET might catch it. How to treat this patient today, whether they as with those with showing metastasis or without metastasis, is actually a gray zone area. But most people feel that if you see meds, you need to treat it. Now we'll focus today on this complicated chart, and we'll keep coming back to the chart. The first thing which you are seeing is, if the patient has become castration resistant, that is, there is progression, it's a PSA only progression, or there is also radiological progression. Let's focus if the patient has PSA only progression. You actually look for the doubling time. If the doubling time is more than 10 months now, you actually have the option of keeping the patient on observation also. You don't have to do, just keep him on close observation. You actually may spoil his quality of life by giving something. However, if the doubling time is less than 10 months, you need to give either enzalutamide, apalutamide, or daratumide. And you would add to the androgen deprivation. Now, let's discuss this and then we can go there. Now, why do you want to add any of these three in a non-metastatic CRPC, which means that there is no radiological progression in this? What has been seen is when you give this one of the three agents, all agents have shown that there is a decreased chances of patient developing metastasis, and it also leads to improvement in lifespan. And you could see the improvement in lifespan is a tune of around, on an average of around 10 months. And if you look in terms of percentage, it's around 7 to 8% at 4 years. And that's an absolute increase in survival which you get. Now, what you also must know that enzalutamide, apalutamide are not devoid of side effects. And that's why the PSA doubling time is more than 10 months. It's better that you avoid it for the patients. Confusion comes now with the current approach. If your patient is really fit, he might get a 3-drug therapy. Then this paradigm may not exist anymore if he gets a 3-drug therapy, because you would have already used the hormonal therapies. Now, to make things simple, we'll follow this simple chart. So, the first chart is very simple. Patient has not received docetaxel, has not received any prior hormonal therapy. Now, usko sirf androgen deprivation therapy diya humne, yes, surgical occlusion. In that, you have all options: abiraterone, docetaxel, enzalutamide, even radium-223 if it's symptomatic bone mets are there, and even sickle cell T. Data for sickle cell T is not that strong. Let's come to the second common situation which actually comes is, we gave prior hormonal therapy and no prior docetaxel, as was in this case. The first agent actually is docetaxel. Now, if the patient was not fit for docetaxel, what to do is a good question. And we would discuss that because giving cabazitaxel is not a good option. There is a first-time trial of dosi versus cabazitaxel, which actually showed that cabaz is more toxic than docetaxel and does not have any advantage. In that case, someone was pointing out genomic study, and I'll take this a bit more in detail. We can do BRCA mutation and HRR mutations and see if we can give Paribar and Ruka Paribar actually oral therapies. Okay. Now, if patient has received prior docetaxel and no prior hormonal therapy, this can also exist, but it's a rare situation. Then you have the option of giving abiraterone, enzalutamide, or cabazitaxel. The problem comes if patient has already received docetaxel and prior hormone. In that, then the category 1 is actually to use lutetium-177 PSMA scan, and this is where PSMA PET actually becomes helpful to tell you whether there is a PSMA uptake or not. And you can also use olaparib. You can also use pembrolizumab. The other agents like cabazitaxel, docetaxel, rearrangement, and mitoxantrone also come into this picture in this situation. Okay, so this looks complicated, but if you know that there are agents which you can use, chemotherapy में agent है docetaxel, वो use हो गया तो cabazitaxel और mitoxantrone. Hormonal में abiraterone, enzalutamide, apalutamide. Then you know that whichever has not been issued, you try to fit into that. Okay, and if everything is related to lutetium, is never forget the nuclear medicine people. Okay, that simple way you can remember. Now, remember I told you, when you add a 3-drug therapy, the advantage was androgen depression to 30 months. With docetaxel or abiraterone or enzalutamide, it used to go to 40 to 50. But when you add 3-drug, it went to 60 months. Which is that benefit was absolutely increased in terms of 10 months. Now, remember, whether you could abiraterone, whether you could docetaxel, enzalutamide in CRPC, the average benefit in terms of overall survival is very small. 4 months, 2.54 months, 2.4 months. So you should be very sure that your patient is going to tolerate these therapies. If your patient is not fit for these therapies, don't push for these therapies just because they are given in guidelines. Because the benefit is small. It is only 2 to 4 months average improvement in survival. Okay, so use them. They're good, but they need to be used very judiciously. Okay, and that's why I told you the amount of benefit you're going to get when you add them in a hormone sensitive is much more than what you get in CRPCs. So this paradigm will change as the time passes by. Now, I'm just showing you the curves because normally now when you read in books, na docetaxel dena hai, cabazit dena hai, it seems very fancy. See, this was the curve at 5 or 6 years. There is a difference which is of around 2 months. But you could see the curves are really not that great to tell you that, okay, docetaxel dene se utna zyada fayda ho jata hai. That's why I'm telling you in CRPC, it should be very clear that your patient is going to benefit, then only you do. Let's look at the other way around, enzalutamide, which nowadays, which in most situations we actually give in hormone sensitively. But don't get impressed by this curve. This is because it is in months and this is in 24 months. This was in years. The separation was looking good. The separation is nearly the same of 2 to 4 months only. Okay. So, and what I'm trying to tell you is, okay, choose your patient appropriately. There is no need to give the patient just because treatments are there. If the patient is fit enough, then only give it. And you can see in abiraterone, actually separation starts only after 18 months. And the separation is very minor. Okay. So the message what I'm trying to give is CRPC, if the patient is fit, try to give these agents upfront. The amount of benefit you get is more. When the patient is probably not fit for a triple drug therapy, the amount of benefit you're going to get in giving subsequently docetaxel or abiraterone or enzalutamide or cabazitaxel is very similar. What I'll do is I'll take you on another presentation now, and I'll share you something for CRPC. But before that, I'll just look if there are questions in chat box. We'll take that and give explanation, and then we go for this. Patient is having liver mets, then lutetium PSMA. So actually, any nuclear medicine therapy, maybe for any reason, does not hold you back to give it if there are like lung mets or liver mets. What is done is in any nuclear medicine therapy, they actually see what is the kind of uptake there, and the uptake is there, you can give it. But your point is correct. When they are visceral mets, most of the times they are not that great. Okay, there is a question from what are the responses, and that is very good question. So understand, we have two types of responses: PSA response and radiological response. In CRPC, unlike HRPC, PSA response with enzalutamide, abrated, docetaxel, if not used priority, each of them is around 40 to 50%. Radiological response, which means shrinkage on scans, is seen only in 10% of the patients. So understand that radiological response in CRPC is rare, and that's why don't be under the impression that बहुत ज़्यादा visceral mets है तो बहुत shrinkage आने वाला है. नहीं, it happens only in 10% of the patients, and that is the reason that this CRPC is a very sad story than what you see in here. We'll go to, there are questions for now for BRCA testing, and also we'll take that. We'll go to this. So now, why do we need to target DNA repair in prostate cancer? I'll just tell you about the DNA repair in short. Now, there are two kinds of DNA. There are single-stranded or double-stranded. Double-stranded are dangerous. Single-stranded can be repaired. Single-stranded repair is done by base excision repair, mismatch-mediated repair, and nucleotide excision repair. Now, mismatch repair, when it's damaged, at that time the patient is very sensitive to immunotherapy, and immunotherapy is approved across all cancers anywhere if mismatch-mediated repair is damaged. Now, if you look at base excision repair, you can see PLOP, few genes like PAR, PAR2, which work in the base excision repairs. Now, double-stranded breaks, the breaks in both strands of DNA, can be repaired by only two: homology directed repair or non-homologous end joining. And this is where PARP inhibitors or the PARP enzyme has a big role. Now, why it is important? Now, understand that the cell can be killed only if there is a double-stranded break. A single-stranded break gets repaired. When you look at this double-stranded break, homology directed repair, BRCA, BRCA2, RAD genes, they play a very important role in joining them. If double-stranded breaks do not get joined, the cell will be in all likelihood getting killed. Apart from BRCA, ATM, ATR genes are also involved in double-stranded break repairs. These are some things which you must know. DDR means DNA damage repair. DRD means DNA repair deficiency. HR means homologous recombination, and all are these genes which are included in homologous recombination repair. HRR means homologous recombinant repair or homology directed repair. These are all genes which are included for the process of homologous recombination. And if there is a deficiency in any of the genes, we say homologous recombination deficiency. In prostate, we look at the HRR scores. We look whether all these genes are there for the double-stranded DNA repair to happen or not happen. And I'll explain you what happens actually. Let's look at this. It's a normal cell. You gave the DNA damaging agent. There's a single-stranded break or a double-stranded break. If it's a double-stranded break, the BRCA via the HR-mediated pathway will heal it. A single-stranded break, the PARP will also heal it. Now, what happens when you give a PARP inhibitor? A single-stranded break cannot get healed. It will cause more twisting of the DNA, and that would lead to a double-stranded break. So what happens in the BRCA mutated cell is when you stop this BRCA is mutated. So already any double-stranded break will be double-stranded. But even a single-stranded break will get converted into a double-stranded break. And this is known as a principle called synthetic lethality. And on this basis, this PARP inhibitors have been tried in prostate. The question comes, how many percentage of your prostate cancers will have these kind of issues? Now, we don't have data from India, but we have data across the world, which shows that in 19% of patients of prostate cancer, you have germline mutations. I'll come to what is germline and what is somatic. And if you add somatic, it actually increases to 27%. So what do you mean by germline? Germline means it is there at the time of formation of the embryo, which means either in the ova or the sperm there was a problem, or in both and you had a mutation. Now, if there's a germline mutation, it will be carried in all cells of the body from the hair to the toe. And so it will be seen in the prostate also. So for germline mutation, you don't have to do the testing on the biopsy. You can do the test on the blood and you will get it. Okay. Now, somatic mutation means there is no germline mutation, but the cancer acquires this mutation by a random process. Now, so what would a smart oncologist do? A smart oncologist will actually test this testing on the tissue. The tissue which has the prostate cancer will be able to catch both germline also and somatic also. So if you get a test positive on the tissue, it means the patient either has germline or has somatic. Now, are there any clues which can tell you whether this is germline or somatic? Yeah, there are clues. There is something called VAF, variant allele frequency, which means if there are 100 reads, how many reads actually show the mutation? Somatic mutations are seen in small, 10%, 20%. If it's a germline, so understand, see, how does the NGS happen? You take the tissue, तुम tissue को disintegrate करोगे, उसमें से DNA extract कर लोगे. The DNA of tumor also will come. The DNA of normal tissue also will come. The DNA of RBC also will come. DNA of neutrophil also will come. Now, the somatic mutation, only the tumor tissue will show the mutation. So the reads will be less. If it's germline, the tumor, the normal, the RBC won't show. RBC doesn't have a DNA actually. The neutrophil, the lymphocyte, everything will show the mutation. So the reads are higher. So anything on tissue, if it is there, it can either be germline or somatic, and then you need to do the blood, lymphocytes of the blood to check it. You can also do it from the buccal mucosa swab. You can even get if it is germline, you will get anywhere. Even if you pluck the hair and take the bulk of blood, you will get it. Now, if you look carefully in this, you will see that BRCA2 constitutes the major part in the prostate cancer, which we all know. Now, what has happened is, over the years, olaparib and rucaparib in 2020 have got approval. Now, let's see why they got approval. So, let's look at this study in which single-arm study, they give it rucaparib in these patients. And let's see what happens. Now, remember, how many patients respond, I told you, with docetaxel? 10 to 12%. And that is it. Now, look at the number of patients who responded when you give this oral therapy, even in CRPC. If you go back and see, here, most of the patients have received androgen directed. They also have received taxanes. In spite of that, 43% of your patients responded. PSA response also was 50%. So this kind of therapy is actually good in this kind of patients who are not fit for even chemotherapy if you have. But understand, this would be applicable only in 27% of a patient, means 1 out of 4 patients. Now, has this got tested in a randomized study? So Triton, there is a randomized study in which if the patient had BRCA1 or BRCA2 ATM mutation, rucaparib versus physician choice. And physician choice was anything, abiraterone, enzalutamide, docetaxel. What it actually shows, these results are not yet out, but it seems that the primary endpoint of the study has been met and the full paper is yet to be out. Now, there is a similar study done for olaparib also. Olaparib is a sister, the PARP inhibitor. Olaparib was the first generation, rucaparib is the next generation. Similar study done for olaparib, and if you look here, they have divided into BRCA1, BRCA2 ATM versus other mutations. And these are a long list. BAR, CHEK1, CHEK2, FNAC, PLAB, RAD genes also. What they saw was, okay, the patient benefit, there's a survival benefit also. And hence, both olaparib and rucaparib have got approvals. And if you look at, there are other drugs also, like niraparib, which have got approval. What I'm trying to show you is, let's say that there is no BRCA mutation, but there are other genes, RAD gene, CHEK gene, ATM genes, wo kaise respond karte hain. And you see, the response is not that great. You saw that response there was around 43.5%. In the other ATM, CDX2, CHEK2, the response rate is not that great. it is around 10% or in around 30%. So what you must understand is patient who had BRCA1, BRCA2 mutation, they are the patients who benefit the most. The other gene patients actually have limited benefit with these drugs. Now, I won't bore you with more details about these drugs. I'll show you what is in the future with these drugs. Now, what is the future with this drug is this. We have now drugs which have been tried in the first line setting where PARP inhibitors have been combined with abiraterone. So docetaxel they're trying to remove because we all are afraid of docetaxel. Docetaxel has quite a bit of side effects. So olaparib plus abiraterone, all these trials are going on. So it may so happen that next year, if I'm taking this class, I might be telling you about one of these agents which have better view. With that, I will stop. So what would be in today's world an ideal way of treating a patient who has received therapies? If he has not received any novel therapies, not received any docetaxel, the first choice can either be novel therapy, that is abiraterone and enzalutamide, or you can give docetaxel. Knowing that there is now the Triton data is out, which shows that if the patient has BRCA1, BRCA2 or ATM mutation, it is better, the giving an olaparib or rucaparib is better than if he has genomic signatures, he can receive that therapy. If the patient has already received docetaxel, but no hormonal therapies, you can give hormonal therapies or you can give PARP inhibitors if there is the mutation of it. If patient received both docetaxel and both hormonal therapies, then your actually choices are limited. Lutetium is your choice. You have PARP inhibitor is your choice. MMR deficient and immunotherapy is your choice, or cabazitaxel, rarely point toxic drug is your choice. So these are the choices which you have. But remember, one I'll just share because there's one more important slide you must understand. And this is the slide which I wanted to show you. You must discuss with the patient the goals of therapy. In CRPC, the benefits which are adding in most of these patients are limited. So you must understand the expectation and preferences of these patients. You should check for bone modifying agents if they have not been started and bone meds are there, please start them. Do an interaction check. Many of the times they are on multiple drugs, and take a palliative care reference for these patients because many of them are going to end up with that. Okay, so that is in short and a gist of CRPC. I'll take the questions which are in the chat box and then we can, if there are any further questions, I'll take it. So okay, there's a question on indication for genomic testing and availability in India. So the indication for genomic testing actually starts at present when the patient develops CRPC. Yes, they are available in India. The prime labs like MedGenome, SciGenome, all are doing it. There is a catch, but most of these drugs get approval with what is called as companion kits. The companion kit here actually was the foundation CDM testing, but foundation is very costly. It costs around 3 lakhs. In India now with these genes, you can get it done at 20 to 30,000 itself with Folbase, MedGenome, or with the other labs. Should ADT be continued once CRPC is diagnosed? Yes, ADT is lifelong, so you need to continue ADT. Pembro, if Kabazi is contrary, yes, but Pembro only if the patient has MSI instability, or else sir, Pembro actually doesn't work. BRCA2, yes, olaparib, abiraterone, enzalutamide, cabazitaxel. So cabazitaxel actually is a horrendous drug. I have been involved in the phase 3 of cabazitaxel. I've given it also, and I've given it in head and neck cancer also. It's a very bad drug. Tolerating 20 milligram per meter square of cabazitaxel actually takes a lot of out of the patient. And frankly, the benefit of cabazitaxel was actually 1.5 months. So in my practice, I limit cabazitaxel a lot unless the patient is very fit and wants to do that. That is it. Yeah, that is it. Yeah. So what genomic testing I would go? I would actually send it for a panel of HRR testing, that is homologous recombinant repair testing, which will cover both the BRCA1, BRCA2, ATM, all the red genes and the MMR genes also. So, is there any questions I'll take?
The many time, the question arises in students' mind is, when you've done bilateral orchidectomy, what will be the result of doing a serum testosterone?
It should be, according to me, below 5 nanogram per ml. According to me, I have never done it. If anyone has any experience, they can share.
So there is no need to say in exam, correct?
Yeah. According to me, no.
Yeah.
Unless it's a subcapsular orchidectomy which someone has done and left some tissue behind, I don't think there is.
Yeah, like not a total like orchidectomy, but subcapsular if they have done, sometime it may show, increase. Right.
So, sir, as you know, examiner may ask why somebody will do subcapsular.
Yeah. I didn't get the question. Can you be a bit more loud?
I ask why someone will do subcapsular orchidectomy. Why?
I don't know why someone.
Yeah.
This is. I've seen only one case in my life, and that patient's testosterone also was.
Yeah. So there is reason because some patient ask for the testicular prosthesis post orchidectomy. So what happen if you leave the capsule and you just remove the parenchyma of the testis? So when it forms the hematoma, right? So it gives the false feeling of the testis. Okay, that's why this subcapsular test, this thing orchidectomy was popular. But nowadays it is obsolete. One should not do that actually. If you do for any reason, this is something very dangerous for you in future. So nowadays nobody does that.
Now someone has asked about the whether we should do bilateral orchidectomy and at the same settings we should do TURP. The question is, many times earlier also we have discussed it, that it should not be done, because many times after doing ADT, that is bilateral orchidectomy, maybe after 3 weeks, 4 weeks, the tumor will shrink and patient will not have any obstructive symptoms. So we must give them chance. If we, like in this case, first we did orchidectomy, we waited, but still the symptoms persisted. So we went ahead and did the TURP.
So, sir, one situation where a patient having CA prostate or with hematuria, in which the tumor tissue is bleeding. Okay, in that scenario, you can do TURP with orchidectomy if it is indicated.
Yeah. So whenever there is a complication and which indicates that one has to go ahead.
Otherwise, as sir said, you should wait for the hormone therapy to act, and there is no harm in waiting for 1 more month.
But this is not for the exam, just for the practical. If you find that the mass is big, patient is not going to follow up, or he is going back, in his town, and there are many other reasons like. So that is the only case when you can go ahead and do both the things together. But this not to be answered in exam. This is only the practical.
Yeah, but until somebody asks you specifically.
No, this can be told in exam also, sir, because if it is simply acute urinary retention and due to outlet obstruction by malignant tissue, then that can be reduced, and whatever concept you have placed, that stands true in 50% of the cases. But when the patient presented with the complication of outlet obstruction secondary to the CA prostate, as Mahendra is saying, in such situation, we have to go ahead with URP along with the bilateral orchidectomy.
But only if only patients gives consent of orchidectomy, only then.
No, so if you already plan orchidectomy for as a hormonal treatment or surgical castration, along with that,
Yeah.
to do a TURP or not is the question what we are discussing, if I am not wrong. And in such situation, if the indications only for to go ahead with TURP along with bilateral orchidectomy is a patient having a complication of BOO secondary to the malignancy. That as you told, like hematuria, presence of some
Yeah.
stones, some presence of upper tract obstruction, back pressure changes. These are the some few indications you can go ahead with. You cannot wait.
Yeah, it is justified in that.
And if it is only simple acute urinary retention, then doesn't matter month you can wait, and there is a chances of having a 50% reduction or 50% cases patient may pass urine without going for TURP.
So this is important. 40 to 50% of patient they
Agree.
don't respond with the ADT. So you have to keep watch. Okay, and explain the patient that maybe we are giving ADT, you may not respond, and you may require TURP in future.
The Achin is asking that how often you should repeat the PSA.
So Dr. Vijay, are you there?
So it is actually dependent upon how if the patient has symptoms, if the patient doesn't have symptoms. Let's say that the patient is absolutely asymptomatic, and I see that after the Nadi there's a rise in the PSA, I would actually call him after 3 months only. I won't be calling him early. But if there's a rise, let's say the PSA was 3 and suddenly I see a jump to 13, then I would want to call him after a month and recheck it whether it is still rising or not rising. So there is very limited guidelines here, but this is what is practically done. If there's a very small rise, then let it be on the next follow-up itself. If it's a substantial rise or you're concerned with the rise, then it's better that you call him up after 1 month and just check it. The next thing is, it's a very simple thing, but it's better to get the PSA from the same lab. Many times the difference in the lab also makes a big of difference. So it's always important to tell the patient that please do it from the same lab.
Just to add in this, Tanmay, can you tell me why Dr. Vijay asked to call the patient every month for serum PSA?
So because with the symptomatic metastasis, with the rising PSA, there's
something called doubling time, PSA kinetics.
Yeah, to look for the PSA doubling time. Yeah, if the PSA doubling time, as you mentioned, is less than 10 months.
Okay. Yeah, and second thing, which Dr. Vijay specifically told about, do the same lab. Again, the lab is specific, because sometimes if you see the report, you will see the report in your training period, the serum PSA more than 100, more than 150. Whether it is in thousands, is it into 200? It is not clear. That means those labs have substandard machines which cannot detect more than 100 serum PSA. Okay, so lab should be specific. It's a good lab because the variation in the value of serum PSA is different in different labs. So this is a very important point we should remember. Yeah. I think, sir, anything to be discussed else?
No, unless and until there are some questions in the chat box, or if the students want to know anything more.
Yeah.
Is there any specific timeline for the channel TURP? Because I couldn't find it anywhere in the thing. We usually follow 2 months, but then
No. Again, just like acute retention of urine, patient where having a failed catheter-free trial, okay, as ADT is not working, you have to make him catheter-free, right?
Yes.
So you have to wait to conservative management, just you do in the normal prostate. Okay, it is the indications are same.
Okay.
Yeah. Sir, Gaurang sir.
Yeah, I think he has covered everything in these 2 clinics, and patients, I'm just saying, students have benefited a lot. And of course, Achin wanted the slides, but everything is recorded. So Achin, you can again go and again listen to this lecture, and it will be very helpful to you. And it will be helpful to basically all the students. So in case if you have got any questions you have not understood, or if you come across something, please post it on a group. We will also ask Dr. Vijay to answer it. Fine? Okay?
Okay.
Okay. Thank you. Thank you, Vijay. And
you, sir.
as we continue our clinics PG update, as far as the malignancy is concerned, now we want to finish off. So whenever your part is there, we will inform you. So please join us.
Sure,
at that time.
sure, sir. I'll do
Right.
it. Don't worry.
Okay. Okay. Thank you very much.
Okay. Yeah. Good night, everybody. Thank
Good
you.
night.
Vijay
Good
sir,
night,
Mahendra
sir.
bhai,
Good
Gite
night,
sir,
Hiren bhai.
Gaurang sir.
Good night, Vijay sir. Good night. Good night.
Good
Bye.
night.
Bye.
Bye.
Good night. Tanmay, you answered very well. So he left.